Next, we'll talk briefly about SLE. This is also a vasculopathy. About 50% of those patients with SLE develop a neuropsychiatric SLE. At the onset of neuropsychiatric SLE, you have small vessel disease in greater than 50%, so this causes accelerated small vessel disease. You see stroke in about 13% of those with neuropsychiatric SLE. So the mean age of this is at 41 years of age. And you can also have immune-mediated vasculopathy as well. We'll talk about post-anoxic encephalopathy, which is an interesting clinical condition that occurs after a severe anoxic episode. Patient typically recovers about a day or two after the severe anoxic episode, but then goes on to have precipitous decline about 2 weeks after the initial episode. These patients progress from confusion to coma and then death. The cause is believed to be allergic demyelination from myelin antigen exposure during hypoxia, and then patients have demyelination necrosis that occurs. So post-anoxic encephalopathy, you see T2 hyperintensity throughout the white matter. You have involvement of the corpus callosum, the subcortical U fibers, the internal and external capsules, and you see diffusion restriction. So this is a case of a 69-year-old woman who had elective plastic surgery outside hospital, followed by respiratory depression due to narcotic overdose. Patient presented with severe worsening mental status over the following 2-3 weeks. This is a case from my fellowship, so then the patient presented to our to MGH hospital. And so what you see is right here, you see diffuse T2 hyperintensity involving the white matter, including the subcortical U fibers. It's showing diffusion restriction. This is a very old case. With diffuse symmetric diffusion restriction involving the corpus callosum, the white matter, including the subcortical U fibers. Post-anoxic leukoencephalopathy. Next, we'll talk about the fairly common entity you should know about called posterior reversible encephalopathy syndrome. The cause is believed to be the inability of the posterior circulation to autoregulate. So you have less innervation of the posterior circulation by sympathetic nerves compared to the anterior circulation. And this can result in hyperperfusion and blood-brain barrier disruption. And what you have is leakage of fluid from the intravascular space into the interstitial space, resulting in subcortical edema, which is why this typically initially presents with vasogenic edema and not cytotoxic edema. It's associated with hypertension most commonly, but other etiologies can result in it related to endothelial damage or dysfunction. And patients with PRES typically have confusion, they have headaches, seizures, drowsiness, they can have nausea and vomiting, as well as visual disturbance, since it's posterior predominant. On imaging appearance, what you'll see is T2 hyperintensity in the cortex and subcortical white matter, specifically in the parietal and occipital regions most classically. It's usually reversible. It can extend to involve other lobes. It can involve the temporal lobes, the frontal lobes, the pons, the cerebellum. They may or may not enhancement, may or may not have areas of susceptibility effect. There's a huge list of associations with PRES. The most common is hypertension. You also want to make sure to see the patients on any immunosuppressants, such as cyclosporin or tacrolimus. Patients with preeclampsia and eclampsia have increased incidence of PRES. Patients with SLE who are on cisplatin with any renal disease or cocaine have increased incidence of PRES as well. This is the case of a 33-year-old man. Has a history of double lung transplant. He's on tacrolimus and he has headache. This is a fairly classic imaging finding of PRES, where you see T2 hyperintensity involving the subcortical white matter, again posterior predominant, involving the occipital lobe and the posterior temporal lobe here. There's no associated gradient abnormal signal, no associated diffusion restriction. PRES can be associated with this condition called RCVS, otherwise known as reversible cerebral vasoconstriction syndrome. On imaging, what you'll see is non-aneurysmal convexal subarachnoid hemorrhage. You can see vascular narrowing and dilatation in the peripheral or central cerebral vessels. And you can see posterior white matter involvement without infarction with the imaging appearance of press. And patients present typically with a thunderclap headache. It's sudden and it's recurrent. And the way you diagnose RCVS is with angiogram. You can do CTA or MRA, but it's not as sensitive. Next, we'll talk about a condition known as inflammatory cerebral amyloid angiopathy. This is a rare condition, but I've seen 2 cases so far as I've been here. It occurs due to inflammatory response to beta amyloid in the walls of the leptomeningeal and brain blood vessels. Clinically, the mean age of onset is the 7th decade, so it occurs in an older individual. And the onset of symptoms is typically acute or subacute and can be variable. Patients can have headache, cognitive decline, encephalopathy, seizures, and focal deficits. Imaging appearance, which you'll see as white matter lesions, may or may not have much mass effect. There may or may not be patchy enhancement or parenchymal enhancement. But what's important to look for is multiple lobar and peripheral microhemorrhages. And the differential considerations for inflammatory amyloid angiopathy with these areas of susceptibility effect include press or ADEM, and the age is very helpful in distinction. And the extent of susceptibility effect is also helpful in the distinction. So this responds well to immunosuppressant therapy. Here's an 81-year-old. The history of trauma, there was no other history provided to me at the time. What you see is there's these areas of extensive susceptibility effect extending throughout the peripheral lobes. So it's one of the frontal lobes, the bilateral posterior temporal and occipital lobes here, and the parietal lobes over here. You have the temporal lobes medially involved and more laterally involved. And there's no associated diffusion restriction. There's quite a bit of confluent T2 hyperintensity along the subcortical and periventricular white matter corresponding to these lesions. There's only mild mass effect. It's not that significant when you take into account the degree of the T2 hyperintensity of these lesions. And it's quite multifocal, no diffusion restriction. So this patient actually had prior hospital study upon further review, and this was from just 2 months ago and you can see that it just has progressed to some extent, but was present also before. And this was a case of cerebral amyloid angiopathy.